Okay, perfect. And so thank you so much for asking me to talk about this topic that's very close to my heart. And as a physiatrist, I think that this is what we as a group in rehab can really contribute towards. And so I'd like to basically talk about three things today. I want to review the current knowledge on prognosis after traumatic spinal cord injury, and also to help us understand how prognostication after spinal cord injury can be determined by clinicians, and also to discuss how rehab goals can be based on accurate prognostication. Now, before I start though, I just want to do a little poll here. So Lei, I'm just wondering if you can share the information on how to use the Mentimeter here, please. Because I want to basically understand who we all are and what discipline we are, and also where we come from. So I'd like to have some fun and use the Mentimeter. So Lei, I'll turn this over to you to show us how to use that. Oh, I beg your pardon. I didn't realize that. So Lei put it in the chat. Sorry, I wasn't focusing on the chat when I'm presenting. So Lei did put in the chat. If you haven't seen that, go to www.menti.com and then enter the code 86969002. And I should do this myself too, so I can see what the questions are. Okay, so are we all ready for the first question? I'm going there myself. Okay, so the first question is, which stakeholder group do you identify as today? So do you all see this question on the screen for the poll? And if you to check on that, you may identify yourself with more than one group, but please choose the one that you feel to be the most representational of yourself today. So representative, whatever the word is. And so please submit, and then I'd love to see who we all are. And if we are ready, can we show the results, Lei? Okay, let's show the results so that we can move on with the presentation. Okay, it seems like 79% are care providers, and followed by healthcare leaders and researchers. So, okay, so most of us are providers here. Great, thank you. And now I do have the next question also. And so if you want to go back to your Mentimeter, now, where are we from? And so please vote now, and then we can see where we are all from. Okay, how are we doing? Shall we take a look? Okay, so it looks like a lot of us are from the Calgary zone, and then followed by the Edmonton zone, and oh, thank you, Dalik. I saw your message. Oh, thanks so much for joining from the North Zone, Dalik. Appreciate it. Perfect. And now I actually want to do one more question before I move on with my presentation. So the next question, please, Lei. And now this question is related to my presentation today. So as a clinician, for those of you who are clinicians, do you feel that it's your role to provide prognostication to someone with a new traumatic spinal cord injury? So let's vote there. I want to see what you think now, and I'll repeat this question actually at the end. Okay, so I see that we have about 40% who think that, or 50 now, who think no, it's not your role, and then 28% who said yes, and 22% who said not sure. So guess what? I'm going to jot down these numbers because I would like to see if we may change our mind afterwards. And so, okay, thanks so much, Lei. And so let me actually share my screen again. Perfect. Okay, great. Can you see my slide again?
Yes, you can see them.
Perfect. Okay. And so now the outline of my talk is that I want to talk about neurologic evaluation for prognostication, and also including some of the current literature on prognosis, and then just talk about functional goal setting together. So let's go straight into neurologic evaluation. So why are these evaluations important after SCI? Basically, they can help us determine the neurologic status rather just than just the anatomic status of people with SCI, because we can hear that people say that they have, fractures at C5 or T12. But actually, in order to understand people's prognosis, it's important to know about the neurologic level of injury, which I'll go into, rather than the anatomic level of injury. And also we can set functional goals for the patients and families, and also for ourselves. And if we repeat the evaluations, basically we can detect if there's any improvements or deterioration of the neurological status. Now, one way of doing this is the international standards for neurological classification of spinal cord injury, or now we call it INSCI, or previously known as the Asia classification. Asia because it stands for the American Spinal Injury Association. And basically, this is now the standard that people use for the neurologic classification after spinal cord injury. And very quickly, what are the components of INSCI? So there are the motor components and also the sensory components. For the motor examination, we examine 10 key muscle groups on each side of the body. So 5 in the arms and 5 in the legs. And also we check the anal sphincter volitional contraction. And for the sensory examination, we check 28 dermatomes on each side and also deep anal pressure. And we check for light touch and pinprick. And so there are lots of things that we check. And these are all just our clinical examinations. I'm not going to get into the details here today as to how you do this, because that would take another lecture to do so. But I just want to show you this worksheet that we use, basically just to show you what we collect. And once we have completed this sheet, we can then look at the sensory level and the motor level, and then come up with these things. So first of all, we have what we call the neurologic level of injury. So, you hear again people saying that, the injury level is C5, T6, and something like that. So that's the neurologic level of injury. And then the AIS refers to Asia Impairment Scale. And so that is AIS A, B, C, D, or E. Or people used to say Asia A, B, C, D, or E. So AISA refers to what people may call it, as complete injuries. And so there's no sensory or motor function that's preserved in the S4 or 5 dermatomes, which is right around the anal sphincter area. And then for AISB, that refers to sensory incomplete injury. And so there's sensory preservation in the S4-5 area around the anal sphincter. And then for AISC, that's motor incomplete. That means that some motor function is preserved. And for AISD, it's also motor incomplete, but it's actually more motor function that's present than AISC. And then with AISE, that's essentially normal function, normal motor function. And so I may be referring to AISA, B, C, D, or E later on. So I just want you to have the reference here. Okay, so as I said, the examination by INSCI is a clinical examination. It is quite simple, but it does require training. And it correlates well with the neurologic status and also with prognostication. And I'll break it down for all of us in the next few slides. And also, INSCI has been found to be useful for specific functional prognostication, like independent ambulation. I'll come back to this point later on as well. And so let's talk about INSCI for prognostication. So just to clarify, right, to prognosticate means that this is from the Collins Dictionary, to foretell future events according to present signs or indications and prophecy. So what we are meaning about here is that we want to know what people's functional outcomes may be by examining their clinical status from the INSCI examination. So let's go through that. So for the INSCI examination, as I said, we are looking at the motor and sensory examinations. And these both actually give us information on the level of injury and the impairment, i.e. the AIS classification. And both this sensory and motor examinations will give us useful information for prognostication of functional recovery after SCI. And all of us, when I say all of us, I mean not just the physiatrists, not just the surgeons, but also the rehab professionals and nurses can actually contribute towards this. And I'll explain to you as we go along. And most studies use the INSCI examination as the initial examination at 48 hours after injury, or 72 hours, or less than 30 days. So you see different times after the injury in the different studies. Now, for the Rick Hansen, the SCI registry, that both Calgary and Edmonton are involved in, we use, I believe, 72 hours after injury. That's when we should be doing our first INSCI examination. So for the motor examination, let's talk about that first. Studies have shown that the motor level can be predictive of functional outcomes. And another study showed that the motor examination at 1 week post-injury may predict functional outcomes. And also we know that for people with C4, 5, 6 injuries, a high percentage of these individuals will gain at least one motor level by 24 months already. So we know that motor examination can help us. And also some other studies here have some more specific information. So this older study by Crozier showed us that the quadriceps muscles, if it shows the strength of more than 3 out of 5 strength by 2 months, that's actually a good predictor for ambulation by 6 months in persons with incomplete paraplegia. So that's really good to know, right? So if you have a patient who's already got 3 out of 5 strength before 2 months, you know that that person has a really good prognosis for ambulation by 6 months. And then another study, right? This study really blew me away when I first read it, and it came out in 2010. the presence of a combination of acute voluntary anal contraction, light touch, and pinprick sensation in S45, so around the anal sphincter, is actually a good predictor of ambulation at 1 year. It blew my mind when I first read this study because we are just talking about the sensation around the anus and also whether there's voluntary anal contraction. And that's it. It's not even talking about the motor strength in the legs. And so imagine, right? Nurses check people's anal sensation and also the voluntary contraction easily, right? So you can potentially participate in this. So just keep this in mind. And so now this study also showed that if you have an initial Asia motor score of more than 50 on admission, and also your AIS classification is less severe, then that's a good prediction of fine motor outcomes at 1 year. And so the motor examination can certainly help us to prognosticate. But how about the sensory examination? Now, pinprick and also sacral sensory exams have been studied. And I already talked about that. And so this study by Olsen showed that if you have baseline lower extremity pinprick preservation and sacral pinprick preservation at 4 weeks post-injury, that's actually associated with improved prognosis for ambulation for persons with motor complete and sensory incomplete injuries. Again, we are talking about people with initially no motor function, right? But if they have pinprick sensation and that's actually really significant because they may have prognosis for ambulation. So that is also very significant as well, because again, we're talking about people with motor complete injuries initially. So now another study just showed that just by having pinprick sensation less than 7 days post-injury in the lateral elbow, which is the C5 dermatome, it predicts motor recovery at the extensor carpi radialis, which is for wrist extension, right? In the C6 myotome. And that's for people with C4-5 injuries. So that's a good way for us to look at how muscle groups may recover. And then if you have preserved pinprick sensation at levels below the injury in motor complete injuries, that predicts functional ambulation. And if you have a presence of pinprick sensation less than 7 days, that also has good prognostic values too. So really, are we seeing a pattern here that actually sensory preservation for pinprick may predict motor recovery? And more recently, this group found that if you have preserved S1 sensation, which is around the ankle, right? That's actually a good predictor of S4-5 sensation around the anus and voluntary anal contraction. That's really interesting too, because basically if you have S4-5 sensation and also voluntary anal contraction, that may help with your bowel and bladder function too, right? And then this study, the last one here, is that light touch before surgery, if present, has the best predictive value for skim at 1 year when compared to other scores too. So what I'm trying to say here is that motor and sensory examinations are very important. And sometimes we think about motor function being the most important, but actually even sensory examination here is showing us that it's got a lot of predictive value. So let's actually do a poll here. What percentage of persons with a new traumatic spinal cord injury that's classified as AISA, or what we call complete injury, initially, right, after the injury, will convert to AIS-B, C, or D in 1 year? So we have 0%, 5%, 15%, 20%, 28%, or 35%. What do you think? So Lei, let's put up the poll here. Thank you, Lei. So let's vote here and see what you think. I'm very curious to see what you think about this one, and I'll talk about this in the next slide. Okay, how are we doing here? Are we good? Shall we take a look? Okay, Lei, do you want to show us the results? Perfect. Okay, so we have 35% who said 28%. 15% is actually coming up. It's now 30% for 15% and 34%, 35% of you said 28%, and 18% of you said 35%, and 14% says 5%. Okay, so let's go back to my slide, and if I may share my screen again. Thank you. So let me go back to my presentation. Okay, so can you see my slide again? Okay. So, okay, so those of you who voted for 28%, you were spot on. So basically, recent studies show that actually for people with AISA injury or classification, 28% were actually converted to incomplete status at 1 year. And half of those will go to AISB, and half actually will become AISC or D. Isn't that amazing? So we are talking about, about 14% of individuals with initial injury classification of AISA who become AISC or D. So when you have AISC or D classification, you may have ambulation potential, right? So 14% is what? 1 in 7 people, right? 1 in 7 people with AISA initial classification may actually become AISC or D. That is actually a sharp contrast to what we knew before from some previous studies. So the most recent studies, not just from Kirschman, but from other studies, all show the same thing, that more and more people seem to be actually converting from AISA to other categories which are incomplete. So I want you to really keep this in mind, because I think that's an important concept for us to think about, especially for rehab planning. Okay, so let's break it down here more. So how about if we break it down by tetraplegia versus paraplegia? So if you have AISA tetraplegia, at 1 year is about 30% again who actually will change to AISB or C or D. And then if you have paraplegia, you convert less so than tetraplegia. Isn't that interesting? Now, how about if you have AISB to start with? If you have AISB tetraplegia, then basically you may 50 to 65% may convert to AISC or D, but if you are AISB paraplegia, 60 to 70% may convert to AISC or D. Remember, AISB is also considered motor complete injury, right, initially. So actually, quite a few people actually improve quite significantly by 1 year and may have motor function. So I think that's such an important concept, because remember, we know that the motor recovery occurs the fastest within the first 6 months, but may still continue over the next year and beyond. So doesn't it mean that we really want to take advantage of that and really focus on rehab for motor recovery, for neural recovery within the first 2 months? I think that's a no-brainer. So we really want to think about that a lot more. Okay, so if you have the level of injury, what does it mean? So lumbar injuries have, the people with lumbar injury have the best recovery prognosis compared to cervical injury or thoracolumbar injury, and people with thoracic level of injury have the lowest recovery rate. Now, also want us to think in terms of a concept of upper motor neuron injury versus lower motor neuron injury, because if we find that people have more of an upper motor neuron injury, right, where the peripheral nerves are still intact, and we can determine that by clinical examination as well, then their bowel and bladder and sexual function may be more preserved than those with a lower motor neuron injury, where there's more peripheral nerve injury, and we can determine that by our clinical examination as well. Okay, so I've gone through all of that. How does it relate to functional goal setting? I just want to spend the next couple slides here to talk about that, because I think that once we have all of these elements, right, the level of injury, the severity of impairment, and also the specific findings in the motor and sensory examination, we may actually be able to do a better job with our prognostication and hence functional goal setting. So I would like to propose, if we don't do this already, that we use the INSCI examination to be an objective way to help us to form a basis for our functional goal setting. And so the INSCI exam can be used, right, in the acute care setting and also admission to rehab to help us think about how people may recover and hence their rehab functional goal setting. And then repeat that as well so that we know how people are improving. So if you look at this guideline here, it's from years ago, but it's still very good. You can download this for free from pva.org. You will actually get in the last section, in the appendix section, a level by level guide to help us understand what the functional goals may be and what the equipment may need to be and what support people may need to have. So that's very helpful. So I want to just finish up by giving you one example here. This is a real patient of mine, a recent patient. He's a 50-odd-year-old man with acute paraplegia after a helicopter accident. Initially, when I saw him in the ICU just 1 week after his injury, he had no motor movement whatsoever in the legs. And he was told by people that he's not going to walk again. And he was devastated. And so when I saw him, right, I did my INSCI examination. I found that his level of injury was T12. But guess what? He got deep anal pressure. He did not really have anal contraction at that time. He did not have motor contraction in the legs, but he had lots of pinprick sensation in most of his lower extremities. I thought, from my knowledge, right, from different research studies before, would he actually convert to a motor incomplete injury? And also, could he have ambulation potential? I thought, given that he was so early on in the, after his injury, and he got all of these findings, right, with deep anal pressure and with so much pinprick sensation in the legs, we really need to think about potential for neural recovery. Okay, so he got engaged in my research study looking at the use of FES bike to actually promote neural recovery. And guess what? Now, 6 months later, he's walking without any assistive device. So I just want to use this case to illustrate how our clinical examination and can really help us to prognosticate and then plan the rehab accordingly. So I just want to summarize here by saying that the INSCI examination is a commonly accepted tool for neurologic evaluation following SCI, and is useful for prognostication because this exam can be done partly by rehab clinicians and also by nursing as well, especially for the sacral examination. Then we can all take part in this. And then once we actually know the INSCI results and the motor and the sensory part, we can all contribute towards the prognostication in the recovery. And then once we know how people may recover, we can then plan their rehab accordingly, right? And also want to emphasize that more recent research shows that the neurologic improvement after spinal cord injury is way better than what people used to think, even for those with so-called motor complete injuries. In fact, I myself do not often use the term motor incomplete because I think that's misleading. When we say complete injuries, people think that there's no connection between like the level above and below the level of injury, right? But oftentimes it shows in electrophysiologic studies and even on the MRI, you can see that the column is still intact. So there's still some connections there. So I would challenge us to think differently and to really start to think about how we prognosticate people differently and how we may plan for our rehab differently from this point on. And so before I finish, just want to go back to the Mentimeter. So Lei, can you put up the poll again, please? Okay, so once again, same question. As a clinician, do you feel that it's a role to help prognostication to someone with new traumatic injury? Let's try this again. Okay, shall we take a look at the results? Okay, thank you. So just to remind us, right, the previous poll showed that 27% felt that we ought to, that it's our role to provide prognostication, and now 65% of you said yes. And previously, 51% said no, and now 24% said no. So I'm really pleased to see that more of you are thinking this way. So I'm very happy about this. So thanks so much for allowing me to share this with all of you today. I think we have now some time for questions.
Dr. Ho, we do have one question. How can we incorporate this evidence into the goal setting of the people with SCI during inpatient rehab?
Yeah, thank you for that. So I think that one way of doing this, actually, there are several things that we can do, right? I think that it was so important for all of us, right, on the same team to speak the same language, meaning if we all understand what INSCI is and also what the neurologic level of injury is and what the AIS impairment scale means. So that's the first thing. And then also really when we talk about goal setting, when we talk about our patients, our clients in the team rounds, team conferences, let's just say clearly, right? This person has this level of injury and this Asia impairment scale. And what does it mean? What does it mean in terms of the prognosis? And then given the prognosis, can we actually customize the rehab program accordingly, bearing in mind that most neuro recovery occurs within the first 6 months? How can we really get going, right? There's urgency in this. We cannot delay the neuro recovery process. So we should really, I think, focus on that.
Sorry, I've got 2 more quick questions and then we'll have to switch to the next speaker. I have one what are some of the reasons that the conversion rates are better? Is that because of improved rehab services?
Yeah, we actually don't know that. I have to say that the original study that people based on was from 1990s from LA. And I think that because it was one study, people really used that as this kind of main study, right? That we all quote from that study. But later on, there are more and more and more studies. They all show the same thing, that actually the previous study was really underestimating. So I don't know if it's because we did surgery differently, because we are now also maintaining the blood pressure better after the acute injury, or what, or whether it's because of EMS changes. I have no idea. They are all possible, but I think that we should just really take advantage of what we see now and see how we can do rehab maybe differently.
Okay, and the last one that we'll have time for, with the studies that predict ambulation potential, do any describe the functional quality of ambulation and or the level of aids used?
Yeah, I think that it really depends on the study, because what we've seen is that different groups have different ways to measure outcomes, and I do not believe that they always, state clearly whether someone is walking with a cane or with a walker or what. I think people describing ambulation, and so we do have to look at some individual studies.